The Statistical Analysis Plan, or SAP, is crucial for an HIV/AIDS trial. What is SAP in HIV clinical trials? Let's precisely understand it.
Here is a general structure for a Statistical Analysis Plan, SAP, for an HIV clinical trial study. Number 1. Title page. Title of the study: a randomized, double-blind, placebo-controlled study of drug X in treatment-naive HIV-infected patients. Protocol number, version number, date of the document, sponsor's name, statistician's name and contact information. Number 2. Table of contents. Table of contents listing all sections and subsections of the SAP. Number 3. Introduction. Brief overview of the disease condition, HIV, and the study's rationale. Overview of the investigational treatment, including its mechanism of action. Summary of the trial design, objective, and population, e.g., treatment-naive HIV patients. Number 4. Study objectives. Primary objective: to assess the efficacy of drug X in reducing HIV viral load at week 24. Secondary objectives: to assess the safety and tolerability of drug X over 48 weeks. To evaluate changes in CD4 plus cell counts. To assess quality of life using the Quality of Life Scale. Number 5. Study design. Type of study: randomized, double-blind, placebo-controlled. Study population: treatment-naive HIV patients aged 18 years and older. Randomization and blinding. Description of randomization process, e.g., 1-to-1 randomization stratified by baseline viral load. Study arms: Arm A, drug X, 500 milligrams once daily. Arm B, placebo once daily. Duration: 48 weeks of treatment with follow-up visits. Endpoints. Primary endpoint: proportion of patients with viral load less than 50 copies per milliliter at week 24. Secondary endpoints: changes in CD4 plus counts, occurrence of adverse events, etc. Number 6. Hypotheses. Primary hypothesis: drug X is superior to placebo in achieving viral suppression. Viral load less than 50 copies per milliliter at week 24. Secondary hypotheses: drug X leads to greater increases in CD4 plus cell counts compared to placebo. Number 7. Sample size calculation. Rationale: describe the assumptions used for sample size calculation, e.g., expected difference in viral suppression rates, variability. Power and significance level. The study is powered at 80% to detect a 15% difference in viral suppression rates at a two-sided alpha level of 0.05. Number of patients: 300 patients, 150 per arm. Number 8. Statistical methods, general considerations, intent to treat, ITT, population for primary efficacy analysis, per protocol, PP, population for sensitivity analysis, handling of missing data, multiple imputation or last observation carried forward, LOCF, methods for missing efficacy data. Efficacy analysis. Primary endpoint: proportion of patients with viral load less than 50 copies per milliliter at week 24 will be analyzed using a logistic regression model with treatment as a fixed effect and baseline viral load as a covariate. Secondary endpoints: changes in CD4 plus cell counts analyzed using mixed effects model for repeated measures, MMRM. Safety endpoints, e.g., adverse events, summarized descriptively. Safety analysis: incidence and severity of adverse events will be summarized by treatment arm. Laboratory values and clinical safety data will be analyzed over time using descriptive statistics and shift tables. Number 9. Interim analysis. Details of planned interim analyses, if applicable. Stopping rules or futility analyses if early stopping is considered. Number 10. Subgroup analysis. Analyses by subgroups such as baseline viral load less than 100,000 copies per milliliter versus their 100,000 copies per milliliter. Sex and age group. Number 11. Sensitivity. Analysis. sensitivity analyses to evaluate the robustness of the primary results, e.g., different methods for handling missing data, alternative model specifications. Number 12, statistical software. Software used SAS version, X.X, or R version, X.X for statistical analyses. Number 13, amendments to the SAP. Any deviations or changes from the original SAP must be documented and justified in this section. Number 14, references. List of relevant literature and guidelines used in the development of the SAP. Number 15, appendix. Example, tables, listings, and figures. TLFs for key endpoints. Derivation rules for key variables. Number 4, study objectives. Elaborated with a real-world scenario. Example, study. Title, a randomized, double-blind, placebo-controlled study to evaluate the efficacy and safety of a novel integrase inhibitor, drug X, in treatment-naive HIV-infected adults. In this hypothetical example, we are testing a new integrase inhibitor, drug X, in a group of treatment-naive HIV patients. This is a common real-world scenario in which new antiretroviral therapies, ART, are tested to determine their effectiveness in controlling HIV replication, improving immune function, and ensuring patient safety over time. Number 4.1, primary objective, example, study, to assess the efficacy of drug X in reducing HIV viral load to less than 50 copies per milliliter at week 24 in treatment-naive HIV-infected adults. Explanation. Viral load suppression, the amount of HIV RNA in the blood, is the main goal of HIV treatment. A successful therapy reduces the viral load to undetectable levels less than 50 copies per milliliter within a certain period, typically 24 weeks. This primary objective is directly related to the overall aim of HIV treatment, which is to suppress the virus and prevent disease progression. Real-world scenario. In 2021, clinical trials for the long-acting injectable therapy cabotegravir, an integrase inhibitor, in combination with rilpivirine showed efficacy in reducing viral load to undetectable levels in HIV-positive patients, much like the objective outlined here. (4.2.1) Secondary objective, to evaluate changes in CD4 plus T-cell counts at week 24 and week 48. Explanation. CD4 plus cells are a type of white blood cell that is a key indicator of immune health in HIV-infected individuals. Successful antiretroviral therapy leads to an increase in CD4 plus counts, showing improvement in immune function. Real-world scenario. The START, strategic timing of antiretroviral treatment. Trial demonstrated that early ART initiation in treatment-naive HIV patients significantly improved CD4 plus T-cell counts, contributing to better immune health outcomes. (4.2.2) Secondary objective, to assess the safety and tolerability of drug X over 48 weeks. Explanation. This objective focuses on understanding the safety profile of drug X, including the incidence and severity of adverse events, AEs, such as drug-related side effects, e.g., nausea, headaches, elevated liver enzymes. Safety data is critical for regulatory approval. Real-world scenario. During the development of bictegravir, a new HIV treatment, clinical trials extensively documented adverse events like mild gastrointestinal issues to ensure the drug's safety before approval. (4.2.3) Secondary objective, to assess the proportion of patients maintaining viral load less than 50 copies per milliliter at week 48. Explanation. A secondary endpoint extends the observation period to assess the long-term efficacy of drug X. While the primary endpoint focuses on 24 weeks, this objective looks at whether viral suppression can be sustained over 48 weeks. Real-world scenario. In clinical trials for dolutegravir, viral suppression was not only achieved by week 24, but also sustained through week 48, leading to its successful use in first-line therapy for HIV. (4.2.4) Secondary objective. To evaluate the development of drug resistance mutations in patients failing to achieve viral suppression by week 48. Explanation. Drug resistance is a significant concern in HIV treatment. This objective aims to identify if patients who fail to suppress viral load develop mutations that make the virus resistant to drug X. Understanding resistance profiles helps clinicians manage treatment failures and adjust therapies accordingly. Real-world scenario. In trials for efavirenz, some patients developed drug-resistant mutations when viral suppression was not achieved. Monitoring these mutations allowed researchers to adjust treatment strategies and optimize future therapies. (4.2.5) Secondary objective. To assess the impact of drug X on patient-reported quality of life using the HIV-specific quality of life. HIV QOL scale. Explanation. Beyond viral suppression and immunological improvements, assessing the patient's overall well-being and quality of life is critical. Antiretroviral therapies may have side effects that affect mental and physical health, so understanding how drug X impacts quality of life is important. Real-world scenario. In the trial for TDF/FTC, tenofovir/emtricitabine, researchers included quality-of-life measures to ensure the treatment regimen did not negatively affect patients' daily lives while effectively managing the infection. (4.3.1) Exploratory objectives. Optional. To evaluate the pharmacokinetics, PK, of drug X and its relationship to virologic outcomes at week 24 and week 48. Explanation. Pharmacokinetics involves studying how the drug is absorbed, distributed, metabolized, and excreted in the body. This exploratory objective would assess whether specific PK characteristics, e.g., plasma concentration of drug X, correlate with better viral suppression outcomes. Real-world scenario. Long-acting injectable ART, like cabotegravir, required extensive PK studies to ensure the drug reached adequate levels in the blood over time to suppress HIV. (4.3.2) Exploratory objectives. Optional. To explore the impact of baseline viral load and CD4+ count on treatment outcomes. Explanation. This objective would explore how patients with different starting viral loads, e.g., high versus low viral load, or CD4+ counts, respond to drug X. This can provide insights into patient subgroups who may benefit most from the treatment. Real-world scenario. The GS6207, an HIV capsid inhibitor. Clinical trial explored whether patients with high baseline viral loads responded differently than those with lower viral loads, aiding in understanding drug efficacy in diverse patient populations. Number 5. Study design. Example study. Title: A randomized, double-blind, placebo-controlled Phase 3 trial to evaluate the efficacy and safety of drug X in treatment-naive adults with HIV-1 infection. This hypothetical study involves testing a novel HIV therapy, drug X, in treatment-naive HIV-1 infected individuals to determine its efficacy and safety. Below is an in-depth exploration of the study design, incorporating real-world scenarios and practices commonly used in HIV clinical trials. 5.1. Study type. Randomized. Patients are randomly assigned to either the treatment group, drug X, or a control group, placebo or standard of care treatment. Real-world scenario. In clinical trials for bictegravir BIC, patients were randomized to receive either BIC or a comparator drug to fairly evaluate efficacy and safety. Double-blind. Neither the patients nor the investigators know which treatment, drug X or placebo, the patients are receiving, preventing bias. Real-world scenario. In trials for cabotegravir and rilpivirine, a double-blind approach was used to minimize biases in patient and clinician assessments of drug efficacy and tolerability. Placebo-controlled. One group receives a placebo, inactive treatment, which serves as a comparison to determine if the effects observed in the drug X group are due to the drug itself and not due to placebo effects. Real-world scenario. Many early HIV treatment studies, including those for dolutegravir, utilized placebo-controlled designs to rigorously demonstrate the new drug's efficacy. 5.2. Study population. Target population. The trial will enroll treatment-naive adults, aged 18 years and older, who have been recently diagnosed with HIV-1 and have not yet started antiretroviral therapy, ART. Real-world scenario. Clinical trials often focus on treatment-naive individuals to evaluate how new therapies perform in previously untreated patients. For example, the ADVANCE trial studied treatment-naive patients to compare the efficacy of dolutegravir-based regimens. Inclusion criteria. HIV-1 positive patients with a confirmed viral load of greater than or equal to 500 copies per milliliter. CD4 plus count greater than or equal to 200 cells per cubic millimeter. No prior use of antiretroviral therapy. No significant comorbidities, e.g. hepatitis B or C. Exclusion criteria. Pregnant or breastfeeding women. Patients with drug-resistant HIV-1 strains at baseline. Significant liver or kidney disease. 3. Randomization and stratification. Randomization process. The randomization will be conducted in a 1-to-1 ratio, meaning half of the participants will receive drug X and the other half will receive a placebo. Randomization will be performed using a centralized, computerized system to ensure impartiality. Real-world scenario. In the DISCOVER trial for the drug FTAF, tenofovir alafenamide, randomization was similarly conducted using computerized systems to assign patients either to the new drug or to a comparator. Stratification. Patients will be stratified based on baseline viral load, e.g. less than 100,000 copies per milliliter versus 100,000 copies per milliliter. This ensures that the groups are balanced regarding their initial disease severity, which could affect treatment outcomes. Real-world scenario. Many HIV trials, such as those for raltegravir, stratify participants by viral load since higher baseline viral loads can be more difficult to suppress. Number 5.4. Study arms. Arm A. Experimental group. Participants receive drug X at a dose of 500 milligrams once daily for 48 weeks, along with standard of care treatment, if applicable. Real-world scenario. In the clinical trial for dolutegravir, participants in the treatment arm received a once-daily dose of the drug in combination with other ARTs. Arm B. Control group. Participants receive a placebo, identical in appearance to drug X, once daily for 48 weeks. Real-world scenario. Many HIV trials, such as those for cabotegravir, included placebo-controlled groups to ensure that the observed effects were due to the investigational drug rather than chance or placebo effect. Number 5.5. Study duration. Total study duration, 48 weeks of treatment, followed by 12 weeks of follow-up, for a total of 60 weeks. Real-world scenario. In the clinical trial of bictegravir, participants were treated for a 48-week period, which is typical for Phase 3 HIV studies assessing long-term efficacy and safety. Number 5.6, primary and secondary endpoints. Primary endpoint. The proportion of participants with HIV RNA less than 50 copies per milliliter, viral suppression, at week 24. Real-world scenario. In many HIV clinical trials, including those for dolutegravir and efavirenz, viral suppression less than 50 copies per milliliter at 24 weeks is the standard primary endpoint. This reflects effective control of HIV replication. Secondary endpoints. Proportion of participants maintaining HIV RNA less than 50 copies per milliliter at week 48. Change in CD4 plus T-cell count from baseline to week 48. Incidence of treatment-emergent adverse events, AEs, and serious adverse events, SAEs. Development of drug-resistant mutations in participants with virologic failure. Quality of life as measured by the HIV QOL scale at weeks 24 and 48. Real-world scenario. In trials for tenofovir disoproxil fumarate, TDF, these same secondary endpoints were assessed to measure both efficacy and safety over a longer term. Number 5.7, dosing and administration. Drug administration, drug X, 500 milligram tablet, or placebo will be administered orally once daily, with or without food. Real-world scenario. This dosing strategy mirrors that of once-daily HIV medications like bictegravir and tenofovir alafenamide, which are similarly given without food restrictions for ease of adherence. Number 5.8, interim analyses. Interim analysis. An interim analysis will be performed after 50% of participants have reached week 24. This will help determine if there is a clear difference in efficacy or if early stopping criteria are met due to overwhelming benefit or futility. Stopping rules. The trial may be stopped early if drug X shows significant superiority in viral suppression or if safety concerns arise. Real-world scenario. In the partner 2 trial, an interim analysis was performed to assess efficacy early, similar to this design. Number 5.9, safety monitoring and DSMB, Data Safety Monitoring Board, DSMB. A DSMB will oversee the safety of participants throughout the trial. The DSMB will review safety data at regular intervals and make recommendations regarding the continuation, modification, or termination of the study based on adverse event profiles. Real-world scenario. Most large-scale HIV clinical trials, such as the START trial, employ a DSMB to monitor participant safety, especially in trials involving new therapies. Number 5.10, blinding and unblinding. Blinding procedures. Both participants and investigators will be blinded to treatment assignment until the trial's conclusion. Emergency unblinding procedures are in place for cases where knowledge of treatment assignment is critical to managing participant safety. Real-world scenario. In trials like Discover, robust blinding procedures are used to maintain trial integrity, with unblinding only in exceptional circumstances. Number 5.11, follow-up. Post-treatment. Follow-up. After 48 weeks of treatment, participants will undergo an additional 12-week follow-up to monitor long-term safety, drug tolerance, and sustained viral suppression. Real-world scenario. Most HIV trials, such as those testing cabotegravir, incorporate a post-treatment follow-up period to assess continued efficacy and identify any late-emerging safety issues. Number 6, hypotheses. Example. Study. Title. A randomized, double-blind, placebo-controlled Phase 3 trial to evaluate the efficacy and safety of drug X in treatment-naive adults with HIV-1 infection. In this hypothetical HIV clinical trial, drug X, a novel integrase inhibitor, is being compared to a placebo in treatment-naive HIV-1 infected adults. The development of hypotheses helps define the expected outcomes of the study and guides the statistical analysis. Number 6.1. Primary hypothesis. Drug X is superior to placebo in achieving viral suppression. HIV RNA less than 50 copies per milliliter. At week 24 in treatment-naive HIV, 1 infected adults. Explanation. This hypothesis reflects the core goal of the study, to demonstrate that Drug X is more effective than a placebo in controlling HIV replication. Viral suppression, achieving an undetectable viral load, is the primary target for antiretroviral therapy, as it is linked to better clinical outcomes and reduced transmission risk. Null hypothesis. There is no difference in the proportion of patients achieving viral suppression between those treated with Drug X and those receiving placebo at week 24. Alternative hypothesis. The proportion of patients achieving viral suppression at week 24 will be significantly higher in the Drug X group compared to the placebo group. Number 6.2. Secondary hypotheses. Number 1. Drug X will lead to a greater increase in CD4 plus T-cell count from baseline to week 48 compared to placebo. Explanation. CD4 plus T-cell count is a critical measure of immune system function in HIV patients. Effective ART helps restore immune function, reflected in increased CD4 plus T-cell counts. This hypothesis suggests that Drug X will not only control viral replication, but also improve immune health by increasing CD4 plus counts over time. Number 2. Drug X will have a similar safety profile to placebo, with no significant increase in the incidence of treatment-emergent adverse events, AEs, over 48 weeks. Explanation. While Drug X is expected to be more effective in suppressing the virus, it should not introduce an increased safety risk. This hypothesis asserts that the frequency and severity of adverse events, e.g., gastrointestinal, liver, or kidney issues, in the Drug X group will be similar to that in the placebo group. If true, this would indicate that Drug X has a favorable risk-benefit profile. Number 6.2. Secondary hypotheses. Number 3. A higher proportion of patients in the Drug X group will maintain viral suppression, HIV RNA less than 50 copies per milliliter, at week 48 compared to the placebo group. Explanation. This secondary hypothesis extends the efficacy assessment to week 48, focusing on long-term viral suppression. Achieving viral suppression at week 24 is important, but maintaining it through week 48 reflects the durability of Drug X's effect. The hypothesis posits that Drug X will continue to outperform placebo in maintaining viral suppression for a longer duration. Number 4. Drug X will not result in the development of significant drug resistance mutations in patients who experience virologic failure by week 48. Explanation. Drug resistance is a critical concern in HIV treatment. The hypothesis here is that even if some patients fail to achieve viral suppression, they will not develop resistance mutations that limit future treatment options. This would indicate a favorable resistance profile for Drug X. Number 6.3. Exploratory hypotheses. Number 1. Baseline viral load will influence the likelihood of achieving viral suppression, with patients having lower baseline viral loads less than 100,000 copies per milliliter being more likely to achieve suppression than those with higher baseline viral loads greater than or equal to 100,000 copies per milliliter. Explanation. Baseline viral load, the amount of HIV RNA in the blood at the start of treatment, is known to influence treatment outcomes. Patients with lower viral loads may achieve suppression more easily than those with higher viral loads. This exploratory hypothesis seeks to understand how Drug X performs in different patient subgroups based on their baseline viral loads. Number 2. Drug X will improve patient-reported quality of life, as measured by the HIV-specific quality of life, HIV-QOL, scale, compared to placebo at week 24 and week 48. Explanation. HIV treatments can affect patients' overall well-being, beyond just clinical outcomes. This exploratory hypothesis seeks to determine whether patients on Drug X report improvements in quality of life, including physical, emotional, and social health, compared to those on placebo. Number 8. Statistical methods. Example study. Title: A randomized, double-blind, placebo-controlled Phase 3 trial to evaluate the efficacy and safety of drug X in treatment-naive adults with HIV-1 infection. The statistical methods section outlines the techniques used to analyze the data generated in the trial, ensuring the hypotheses are tested appropriately and the results are robust and reliable. In HIV clinical trials, statistical methods are crucial for determining the efficacy, safety, and long-term outcomes of a drug. Number 8.1. Primary efficacy analysis. The primary endpoint for the study is the proportion of patients achieving viral suppression, HIV RNA less than 50 copies per milliliter, at week 24. Statistical test. A Cochrane-Mantel-Haenszel (CMH) test will be used to compare the proportion of patients achieving viral suppression in the drug X group versus the placebo group, stratified by baseline viral load, e.g., less than 100,000 copies per milliliter and greater than or equal to 100,000 copies per milliliter. Hypothesis testing. Null hypothesis, H0. There is no difference in the proportion of patients achieving viral suppression between drug X and placebo at week 24. Alternative hypothesis, H1. The proportion of patients achieving viral suppression will be higher in the drug X group compared to placebo at week 24. Type Y error rate. A two-sided significance level of 0.05 will be used. This means that if the p-value from the CMH test is less than 0.05, we will reject the null hypothesis and conclude that drug X is significantly more effective than the placebo in achieving viral suppression. Number 8.2. Handling missing data. Primary approach. Missing equals failure. M equals F. Analysis will be used for the primary endpoint. Any participant without a documented HIV RNA value at week 24 will be considered a non-responder, i.e., viral suppression failure. Sensitivity analysis. A multiple imputation technique will be used as a sensitivity analysis to explore the impact of missing data on the results. MI will use baseline and on-treatment characteristics to predict missing values. Number 8.3. Secondary efficacy analyses. CD4 plus count change. The mean change in CD4 plus T-cell count from baseline to week 48 will be compared between drug X and placebo, using an analysis of covariance, ANCOVA model, with baseline CD4 plus count and baseline viral load as covariates. Long-term viral suppression. The proportion of patients maintaining viral suppression at week 48 will be analyzed using a logistic regression model, with baseline viral load as a covariate. Number 8.4. Safety analysis. The safety of drug X will be evaluated by analyzing the incidence of adverse events, AEs, serious adverse events, SAEs, and laboratory abnormalities over 48 weeks. Descriptive statistics. The proportion of patients experiencing AEs and SAEs in the drug X and placebo groups will be summarized using descriptive statistics, counts and percentages. Comparison of safety outcomes. Differences in the incidence of AEs between the drug X and placebo groups will be analyzed using Fisher's exact test or chi-square test, depending on the data's distribution and cell counts. Number 8.5. Interim analysis. An interim analysis will be conducted after 50% of participants have completed 24 weeks of treatment. This interim analysis will assess efficacy and safety to determine whether the study should continue, be modified, or be stopped early. Stopping rules. The study may be stopped early for overwhelming efficacy if drug X shows a significantly greater proportion of patients achieving viral suppression compared to placebo, based on O'Brien-Fleming boundaries. These boundaries are commonly used in interim analyses to control the type 1 error rate while allowing for early stopping. Safety monitoring. The Data Safety Monitoring Board, DSMB, will review safety data at each interim analysis. A Landamet's alpha spending function will be used to control the overall type 1 error rate, ensuring that multiple looks at the data do not inflate the risk of false positive results. Number 8.6. Subgroup analyses. To assess the consistency of the treatment effect across different patient populations, several pre-specified subgroup analyses will be performed. These subgroups include baseline viral load, less than 100,000 copies per milliliter versus 100,000 copies per milliliter, gender, male versus female, age, less than or equal to 40 years versus 40 years. Statistical method. A Cochrane-Mantel-Haenszel CMH test will be used to compare the primary endpoint across subgroups, and interaction terms will be included in logistic regression models to test for treatment by subgroup interactions. Number 8.7. Multiplicity adjustment. Given the multiple comparisons being made across primary and secondary endpoints, a Bonferroni correction or Hochberg procedure will be used to control for type 1 error due to multiple hypothesis testing. Number 10. Subgroup analysis. Example. Study. Title. A randomized, double-blind, placebo-controlled phase 3 trial to evaluate the efficacy and safety of drug X in treatment-naive adults with HIV-1 infection. Subgroup analysis is used in clinical trials to examine whether the treatment effect is consistent across various predefined patient groups. In an HIV clinical trial, analyzing the efficacy and safety of a drug like drug X in different subgroups is essential for understanding if the treatment works equally well across diverse populations or if specific groups respond differently to the therapy. Number 10.1. Purpose of subgroup analysis. Subgroup analyses in an HIV clinical trial help to: Number 1. Identify if certain characteristics, e.g., gender, age, baseline viral load, influence the treatment effect. Number 2. Ensure that the drug is effective and safe across all relevant patient populations. Number 3. Guide personalized treatment approaches for specific patient subgroups. However, it is important to note that subgroup analyses are often exploratory in nature and should be interpreted with caution due to the increased risk of false positive findings when making multiple comparisons. Number 10.2. Subgroup by baseline viral load. Patients will be stratified by baseline HIV-1 RNA levels, less than 100,000 copies per milliliter versus greater than or equal to 100,000 copies per milliliter. Rationale? Baseline viral load is a well-known predictor of virologic response to antiretroviral therapy, ART. Patients with higher baseline viral loads might take longer to achieve viral suppression or may have a lower probability of achieving suppression compared to those with lower viral loads. Statistical method. A Cochrane-Mantel-Haenszel CMH test will be used to compare the proportion of patients achieving viral suppression in the drug X and placebo groups within each baseline viral load stratum. The interaction between baseline viral load and treatment effect will be tested using logistic regression with an interaction term. Number 10.3. Subgroup by CD4 plus T-cell count at baseline. Patients will be stratified by baseline CD4 plus T-cell count, less than 200 cells per cubic millimeter versus greater than or equal to 200 cells per cubic millimeter. Rationale: CD4 plus T-cell count is a critical marker of immune function in HIV-infected individuals. Those with lower CD4 plus counts are at higher risk of opportunistic infections and may respond differently to ART in terms of immune recovery and viral suppression. Statistical method. The primary endpoint, proportion of patients achieving viral suppression, will be compared within CD4 plus count strata using the CMH test. An interaction term between CD4 plus count and treatment effect will be included in a logistic regression model to determine if baseline CD4 plus count modifies the effect of drug X. Number 10.4, subgroup by age. Patients will be stratified into two age groups, less than or equal to 40 years versus greater than 40 years. Rationale: age can influence the pharmacokinetics and pharmacodynamics of drugs, as well as the immune system's ability to recover from HIV infection. Older patients may have slower viral suppression or may experience different safety profiles compared to younger patients. Statistical method: differences in treatment outcomes, viral suppression and safety across age groups will be evaluated using a CMH test. Interaction terms in a logistic regression model will be used to assess whether age modifies the treatment effect. Number 10.5, subgroup by gender. Patients will be stratified by gender, male versus female. Rationale: gender differences in ART outcomes have been observed in various studies, potentially due to biological, behavioral, and social factors. Women might experience different drug metabolism rates, side effects, or adherence patterns compared to men. Statistical method: the primary endpoint will be analyzed by gender using a CMH test to compare viral suppression rates. A logistic regression model will include an interaction term to evaluate whether the effect of drug X varies between males and females. Number 10.6, subgroup by race, ethnicity. Patients will be stratified by self-reported race ethnicity categories: Caucasian versus African American versus Hispanic/Latino. Rationale: race and ethnicity can affect HIV treatment outcomes due to genetic, social, and economic factors. Some populations may have different responses to ART or varying rates of adherence due to access to healthcare or sociocultural differences. Statistical method: differences in the primary and secondary endpoints across racial ethnic subgroups will be analyzed using the CMH test. Logistic regression will assess interactions between treatment effect and race ethnicity. Number 10.7, considerations in subgroup analysis, multiplicity and interpretation. Subgroup analyses increase the number of statistical tests, raising the risk of type 1 error, false positives. Therefore, multiplicity adjustments, such as the Bonferroni correction or the Hochberg procedure, may be used to account for multiple comparisons. Despite these adjustments, subgroup analyses should be interpreted cautiously and are typically considered exploratory unless they are pre-specified and powered sufficiently. Pre-specified versus post-hoc analyses. Subgroup analyses should ideally be pre-specified in the Statistical Analysis Plan, SAP, to avoid bias. Post-hoc subgroup analyses can generate hypotheses for future research, but should be viewed as exploratory due to the increased risk of spurious findings. Number 11, sensitivity analysis. Example: study. Title: a randomized, double-blind, placebo-controlled Phase 3 trial to evaluate the efficacy and safety of drug X in treatment-naive adults with HIV-1 infection. Sensitivity analysis assesses the robustness of the primary analysis results to various assumptions, alternative methods, or different handling of the data. It helps to ensure that the conclusions drawn from the study are reliable, particularly in the face of uncertainties or data limitations such as missing values, protocol deviations, or different statistical models. Number 11.1, handling missing data. One of the most common scenarios in clinical trials is dealing with missing data, which could potentially bias the results. Different methods of handling missing data can lead to different outcomes, and sensitivity analysis ensures that the primary analysis results are not overly influenced by how missing data is treated. In this HIV clinical trial, the primary endpoint is the proportion of patients achieving viral suppression, HIV RNA less than 50 copies per milliliter, at week 24. For the primary analysis, a missing equals failure, M equals F approach is applied, where any missing viral load data is treated as a non-response, failure to achieve viral suppression. Multiple imputation, MI. In sensitivity analysis, multiple imputation will be used to handle missing data by predicting missing values based on other observed characteristics of the patient, such as baseline viral load, CD4 plus count, and treatment adherence. Multiple datasets with imputed values are created, and the results are pooled to account for uncertainty in the imputed data. Last observation carried forward, LOCF. Another sensitivity analysis may involve the LOCF method, where the last available viral load measurement is carried forward to the missing time points. This approach assumes that the patient's condition remains stable after their last recorded measurement. Number 11.2. Alternative methods for adjusting for baseline covariates. Baseline viral load and CD4 plus count are important predictors of response to HIV treatment. The primary analysis uses an analysis of covariance, ANCOVA, model, adjusting for these baseline covariates. Sensitivity analysis may explore alternative statistical models to ensure that the primary results are not dependent on the choice of model. Alternative model. A logistic regression model may be used in sensitivity analysis to evaluate the primary endpoint, viral suppression, with baseline viral load and CD4 plus count included as covariates. This analysis checks if the choice of statistical model affects the treatment effect estimate. Number 11.3. Sensitivity to protocol deviations. Clinical trials often encounter protocol deviations, such as patients discontinuing treatment or switching to another therapy. Sensitivity analyses are performed to assess the robustness of the results to such deviations, per protocol analysis. In addition to the intention to treat, ITT analysis, where all patients are analyzed according to their originally assigned treatment, a per protocol, PP analysis will be conducted, including only patients who adhered to the treatment regimen as per the protocol. This sensitivity analysis examines whether the treatment effect changes when only those who strictly followed the trial protocol are considered. Number 11.4. Alternative definitions of endpoints. Alternative endpoint definition. In this trial, the primary endpoint is viral suppression defined as HIV RNA less than 50 copies per milliliter. A sensitivity analysis could define viral suppression more stringently, such as HIV RNA less than 20 copies per milliliter, or use a different time point, e.g., week 48 instead of week 24, to assess whether drug X remains effective under alternative definitions of success. Number 11.5. Sensitivity to different subgroup definitions. Subgroup analyses, discussed in the previous section, are sometimes subject to sensitivity analyses to explore the consistency of results across different subgroup definitions. For example, age might be analyzed in different age bands, e.g., 30 years, 40 years, 50 years, to ensure that the treatment effect is not specific to a particular cutoff. Number 15. Appendix. In clinical trials, especially for HIV studies, tables, listings, and figures, TLFs, are critical tools to summarize and present the results. These visualizations allow for a clear presentation of data that helps regulators, researchers, and other stakeholders assess the efficacy and safety of the study drug. In HIV clinical trials, key endpoints like viral suppression, CD4 plus T-cell count changes, and adverse events are often summarized using TLFs. Table 1. Proportion of participants. Achieving viral suppression, primary endpoint. Interpretation. 90% of participants in the drug X group achieved viral suppression at week 48, compared to 64% in the placebo group. Statistically significant, PI less than 0.001. Conclusion. This suggests drug X is highly effective in reducing viral load in treatment-naive HIV-1 patients. Table 2. Mean change in CD4 plus T cell count from baseline, secondary endpoint. Interpretation: drug X showed a significantly greater increase in CD4 plus T cell counts compared to placebo, p less than 0.001 at week 48, indicating stronger immune recovery. Table 3. Summary of adverse events, safety analysis. Interpretation: drug X had a similar safety profile to placebo, with no significant difference in serious adverse events, SAEs, or discontinuations due to AEs. Most AEs were mild to moderate, e.g., headache, nausea. Listing 4. Individual patient data for viral load over time. Interpretation: this listing shows individual patient responses to treatment, which is useful for understanding treatment patterns. Patient 003 did not achieve viral suppression, suggesting potential drug resistance or adherence issues. Figure 5. Kaplan-Meier plot for time to viral suppression. A Kaplan-Meier plot is used to estimate the time to viral suppression, showing the proportion of patients who achieve viral suppression at various time points, e.g., weeks 4, 12, 24, 48. Figure description: the x-axis represents the number of weeks, while the y-axis represents the cumulative proportion of patients achieving viral suppression, HIV RNA, less than 50 copies per milliliter. Separate curves are plotted for the drug X and placebo groups. Figure 6. Mean CD4 plus T cell count over time. A line graph showing the mean CD4 plus T cell count for each treatment arm over the course of the study, e.g., from baseline to week 48. Figure description: the x-axis represents the weeks, 0, 4, 12, 24, 48, and the y-axis shows the mean CD4 plus count. Separate lines are plotted for drug X and placebo. Figure 7. Forest plot for subgroup analyses. A forest plot is used to present the results of subgroup analyses, showing the treatment effect, odds ratio or hazard ratio, for different patient subgroups, e.g., by age, baseline viral load, CD4 plus count. Figure description: the x-axis represents the odds ratio for achieving viral suppression. The center line at 1.0 indicates no difference between treatment arms. Separate rows are used to show the odds ratios for subgroups such as age, gender, and baseline viral load. Horizontal bars represent 95% confidence intervals, CIs.
Many thanks for watching my video and happy learning. Please like, share, subscribe and leave a feedback comment. Many thanks for your support and having a great connection.